we are going to go ahead and get started. If everyone could find their seats. So our next guest speaker is Robert Longyear. Robert is the co-founder and president of Avenue Health. In October 2023, he was appointed to the Washington, D.C. Department of Healthcare Finance Health Information Exchange Policy Board. He is the author of Innovating for Wellness, a book that explores the intersection of health policy and health technology innovation, and a virtual care blueprint, which provides a deep dive into the evidence and programmatic elements of remote patient monitoring programs. His research work has been published by the Institute of Medicaid Innovation, the American Journal of Medical Genetics, the New England Journal of Medicine, and the American Psychological Association Practice Innovations. His work primarily focuses on innovations in healthcare delivery and care management, as well as the application of digital health technologies to healthcare services and nursing labor markets. Please welcome Robert Longyear.
Thanks, Melissa. Thanks for coming today, everybody. We've been working on this for quite a while. It's very exciting to get involved in some of this work over the past year and a half or so. I also learned today that it is in fact the summer solstice, so something special is happening. It's an auspicious day. So I'm going to talk about two specific models, and then I'm going to talk about some sort of policy mechanisms and policy routes that are common in sort of payment reform. So I'm going to do a little bit of an overview and recap of what we've discussed today and some important sort of baseline topics for the two models that we're going to talk about. And then I'm going to talk about sort of a history and overview of value-based payment policy changes that have occurred over the last 12 years, a very high-level summary. We're going to talk about the stakeholders of reimbursement at the federal and state level, and then I'm going to make a few comments on cost. Ultimately, we can sit here and talk about what we think is best for the nurse, but we also have to deal with the sort of the policy situation, which is going to be centered around how much is this going to cost Medicare, state Medicaid programs, and commercial insurers. So that's what I'm going to talk about today. So ultimately, this is our sort of overarching goals for health system improvement. We want to improve population health, we want to improve workforce well-being, we want to improve the patient experience of care. Ultimately, we want to reduce per capita costs. So this is what guides, this is a quadruple aim, it's what guides a lot of what we're trying to do here ultimately. And this is not just about nursing workforce issues, it's also about patient care, it is about cost, it is ultimately about patient experience. So we think this is an initiative that is well aligned with what we've sort of all collectively agreed is important. But historically, over the last, let's say, 12, 15 years, we've talked a lot about workforce well-being issues. We've seen all the papers written, burnout's a problem, all the nurses are quitting. It's true. But we haven't really done anything to reorganize the system or reorient the incentives to solve that problem. We've done a lot of other policy work, which I'll talk about in a minute. So, I'm not going to spend too much time here, but we have a lot of new nursing graduates quitting, first year, second year, within 5 years. We have a lot of nurses that plan to leave the profession, or at least self-report to plan to leave the profession. This is a problem because we know that when we have understaffing, we have turnover, it's associated with increased adverse events, hospital-acquired conditions, readmissions. Ultimately, those come up into cost to our society, to insurance and payers, and to the hospitals themselves. That's not good. I think it's really important, I'm by no means an expert on this, but I just want to set the stage here, is that the scope of practice for registered nurses and LPNs and LVNs and CNAs are really outlined at the state level, just like physician practice. So, what we're talking about here from a federal level and from the payment system perspective, we have to take into account what that scope of practice is. What are we paying for if we're going to pay for activities and procedures, right? What are nurses reasonably able to do independently versus under the supervision of another professional or the supervision of a hospital? These are all sort of important implications and questions that we need to be able to answer when we're looking at reimbursement. The advanced practice registered nurses have done a good job of getting reimbursement. So Sharon and some of our folks here are trying to apply what they've done with APRNs to registered nurses and LPNs and CNAs. There's a little bit of a difference there in certain areas as we've described, right? There's a lot of shift-based care for RNs rather than episodic-based care or procedure-based care. So that's one of the big tensions that we, are going to deal with as we look at models in this space. So nursing care is provided across the continuum in the delivery setting, right? So we have outpatient ambulatory care, inpatient acute nursing, skilled nursing facility and rehabilitation, and then home health and long-term care. So while other practitioners, clinical specialties are involved in this, nursing is also equally, doing unique activities across all of these settings. The next talk is going to be about outpatient ambulatory for the folks who've been doing a lot of work in that space. The models I'm going to talk about are very focused on inpatient and acute nursing care. I was just talking with Rachel. From a higher level public health perspective, we do want to not necessarily focus in on acute care so much. We want to prevent acute episodes of care. So we do want, to think about models of reimbursing nurses that can improve population health and prevent certain episodes of care. At the same time, hospitals are still an essential service, so we're also focusing in there because it is where the majority of RNs are employed, and it's still a critical service, right? We're never going to not need hospitals, even though we're trying to move to a system that incentivizes health care instead of sick care. So, I've been asked this a number of times, and these are some policy solutions that have been tried to solve this understaffing crisis, right? We have public reporting of staffing ratios, right? That's just creating transparency and pressure on organizations to make sure they're staffing adequately. There's been staffing ratio committee policies where a third-party organization establishes sort of what the right amount of nurse to patient ratios or right amount of staffing is on each unit. That is, legislated by states, mandated for hospitals, and there's been minimum nurse to patient staffing ratio policies, primarily in California and Massachusetts. People have been talking about this for a really long time, 20-something years, maybe more. John might know exactly how long we've been talking about it, longer than 20 years. It has not taken off because of fierce hospital opposition, which Rebecca talked about earlier, and so there's nothing wrong with these, it just hasn't solved the problem. If we keep sitting there saying we want to enforce ratios, we want to make these our core policy solutions, which is usually the case, or has been the case for at least the last 20 years, we're continuing to do the definition of insanity, right? So that's part of the reason we think that reimbursement is an area to look at, because it changes the systemic incentives. Right now, hospitals oppose these things because they can't afford to pay for it or they're not incentivized to pay for it. So if we move towards something where we can shift those incentives using payment policy, then we can still do these things in the future after we've sort of changed that financial equation. So these are the current models of payment for hospitals. So I'm going to go into this in a little bit of depth. So Medicare, prospective payment is the major one. That's the inpatient prospective payment system. It is a sort of annually predetermined methodology. It is required, an act of Congress, as a required prospective payment. So, if you want to change that requirement, you have to go back to Congress and you have to allow nurses or hospital care to be reimbursed retrospectively, right? So that's something that we're dealing with in the inpatient environment. Critical access hospitals are still paid under the old system, which is cost-based reimbursement. So most, I'd say half, roughly 3,300 or something like that, are paid under the inpatient prospective payment system, and then the critical access hospitals are still paid by Medicare through cost-based reimbursement. Per diem, which is your sort of room rate, is paid when a patient is transferred, a Medicare patient is transferred to a new hospital. They will pay the old hospital, basically what would have been the prospective payment divided by the expected length of stay, and therefore they get a room rate, right? The point here is that none of those, except for the cost-based one, which is a subset of hospitals and not a very large majority of patients, are not incentivizing effective staffing for nurses. They really do incentivize that cost minimization behavior. Medicaid is largely mirroring Medicare, although there are some that are still fee-for-service payments, certain services that are paid. sort of on a time or activity basis, procedure basis for Medicaid. And then commercial insurance, sometimes you have a flat fee mirroring prospective payment. A lot of times it's fee-for-service, activity, procedure-based reimbursement to the hospitals, and then still per diem for the room rates there. Again, the point here is largely that none of these really ultimately incentivize or has a link to the actual nursing care provided. Most of these are flat rates, they're predetermined on a fee schedule, they're not necessarily, if one patient for the same admitting condition gets, 100% of the nurse's time and the same patient in the room next door gets 0% of the nurse's time, they're still paid the same. And that's what the problem ultimately is when you distill it. The current models reimburse at the average nursing costs and lack a relationship with the actual nursing care delivered to patients, which is what I just said, which incentivize that cost minimization behavior. We really want to move towards a model that draws a clear relationship between the quantity and quality of nursing care delivered to patients, which ultimately allows nursing care in the hospital to be designed and delivered based on the clinical evidence, based on patient safety standards, and to sort of optimize for workforce quality. So Olga, there we go, okay. So Olga and I published this paper in May. This is a concrete model that we've thought about for a long time that fits within the current legislative situation, which is prospective payment. It makes some very detailed adjustments to the current inpatient prospective payment system methodologies. And I'm going to walk you through it right now. We think this is something that is relatively feasible, and I'm going to tell you the pathway that we're hoping to get this through for a demonstration project at the federal level. It can also be done as a demonstration project at the state level. So, number one, we recommend that CMS should standardize and collect workplace quality metrics at the facility level. So just like the hospital-acquired infections, the readmission rates that are already collected, we think they should also collect job satisfaction information, which is largely available at the organizational level already, turnover rates, some of these indicators of what's actually going on in the workplace, because right now we track quality metrics that are sort of the outcomes, but we think we also need to publicly report and understand what organizations are doing to make that workplace better, because we know it contributes to cost of that outcomes ultimately. Two, and what gets measured gets managed a lot of times, right? So this is an issue that we usually handle at sort of a national survey level. So we usually kind of survey nurses and say, oh, they're all gonna quit, right? Well, the organization's responsible for the quality of life at their workplace, right? Think about where you work or where you've worked before. Your well-being is largely determined by the people you work with, how the organization's leadership operates. And so we think that, in reality, we can talk about the nursing workforce issues as sort of an overarching public health issue, but we can also say it's an organizational issue that we should measure and incentivize improvement for from a government level. Two, we think CMS cost reports should unbundle nursing costs from other reported cost buckets. So every year, the hospitals report their service line costs. We think we need to pull nursing cost out, because then we're going to be able to use that data to do some of these new payment models and to build some of this new information. And to John's point earlier, we can learn more about what's going on and what we should be incentivizing or not, and what degree of value certain attributes of nursing and levels of nursing add to patient outcomes and costs ultimately. We actually already do this. It's very interesting. We do it every 3 years to calculate the Medicare wage index. So hospitals do report their nursing wage, nursing wages, the number of FTEs, number of nursing hours. It's all reported every 3 years. So we think something that is similar to that methodology, which is already collected every year, will allow us to do the model that I'm about to walk you through. Number three is we think nursing care payment should be unbundled from the current IPPS system. So there's an operating base payment, I'm going to walk you through this, that covers labor and other costs and expenses that goes into a sort of patient stay. We want to pool nursing labor, inclusive of LVN, LPNs, CNAs, and registered nurses, out of that payment and go through the same calculation methodology, but with some links to value and links to the actual nursing investment of the facility. We'll talk about in a minute. And then ultimately, number 4 is we think nursing care payments should be aligned with nursing sensitive quality indicators and those workforce quality indicators that we think should be systematically collected. Okay, so I'm going to walk you through this. It's very complicated, and it'll probably take a couple of sessions to go through how this is actually going to be working, but this is the current ITPS methodology. It's somewhat simplified, but this is how it works. So the operating base payment is made up of a non-labor related portion and a labor related portion. In this case it includes nursing, but this is from our model, so it says net of nursing. That labor related portion is multiplied by a geographic adjustment. It's adjusted for the average wage costs of the area that hospital is located in. So New York City has a higher wage index than rural Nebraska. Okay? That number is then added together, and that is your operating base payment. Your geographically adjusted operating base payment, if you will. When the patient is admitted, that patient is classified into or technically it's a discharge, but they're classified into an MSDRG, which John explained to us has a weight. It's how complex the case is, essentially. That geographically adjusted amount is multiplied times that patient weight, basically, for how complex the condition is. And then it's creating sort of the case mix adjusted amount that's paid to the hospital. And then there's other policies, the value-based purchasing program, the disproportionate share, teaching hospital status that ultimately leads to the full facility payment for that episode of care, that patient's stay at the hospital. A little more complicated than that, but this is simplified. So what you effectively have is a national average, which is calculated from the cost reports a long time ago, and now it's increased every year by this sort of market basket, just like the inflation CPI. You then adjust for the facility's geographic location, right? So in this case we used a 1.21 wage index, and we ended up summing these numbers plus the multiplication. We got 6,781. This is a hypothetical example. So now we have the hospital sort of geographic adjustment, and then what we do is go into the patient level adjustment. What we want to do is further adjust the facility's characteristics, specifically what they currently spend on average per discharge at the facility level, into this equation, which I'm going to show you in 1 minute. What that does is it says, look, you're supposed to get this amount, and a certain portion of this is going towards nursing. But some facilities spend less of that number on nursing than others do. And so we think the ones that, to John's point earlier, spend less should get paid less. The ones that spend more should get more, but with a quality link. So are they improving quality? Do they have good outcomes? Do they have good workforce outcomes? And that's what the model effectively does.